Malignant otitis externa or skull-base osteomyelitis or a necrotizing external otitis is very important for your theory exam, for MCQ exams and also in clinical practice. So the discussion will be under the headings of what is malignant otitis externa, what is the pathophysiology, bacteriology, how will you stage it, spread, the diagnostic modalities, management and outcome and complications. What is malignant otitis externa? It is nothing to do with malignancy. The name is not in the histological sense. This is infection of the soft tissues of the ear and the surrounding structures, but it is very aggressive and life-threatening infection of the soft tissues of the ear and the surrounding structures, and it spreads very fast to cause periostitis and osteitis of the skull base. So it is not cancerous anyway, but because it is aggressive spread and high mortality, it is called malignant otitis externa, otherwise called a skull-base osteomyelitis or a necrotizing external otitis. Malignant otitis externa, the term was coined by Chandler in 1968. And coming to the pathophysiology, so any trivial trauma like a scratch mark or any injury with buds, anything in the external auditory canal will cause a cellulitis, and this cellulitis later going for an perichondritis, then chondritis, osteitis and then osteomyelitis, and this will affect the skull base. And from the cartilaginous part of external auditory canal, the infection is spreading through fissures of Santorini, which are congenital openings in the cartilaginous part of external auditory canal. Okay, so cellulitis, then perichondritis, after that chondritis, osteitis, osteomyelitis and involvement of the skull base. And from the skull base, it can spread, it can go anteriorly or posteriorly, then medially also, and it can also involve the jugula foramen. So from the skull base, if it is spreading posteriorly, it will go to the mastoid, and if it is going anteriorly, temporomandibular joint is involved, and if it is going medially, it involves the medullary cavity and also the petrous part of temporal bone. And in this case, the Haversian canal of the comeback bone is involved, and the involvement of the pneumatized portion of the temporal bone is a late finding. So the spread is through facial planes and also through venous sinuses, and also involving the Haversian system of the Haversian canal of the comeback bone. But in case of chronic otitis media, there is involvement, early involvement of the pneumatized part of the cavity of the mastoid and also the temporal bone will occur. But in this case, in MOE, the involvement of the pneumatized parts of the temporal bone is a late finding, and it will spread through facial plane and also through venous sinuses. Okay, and if the skull base involvement can lead to involvement of the seventh nerve, and if there is jugular foramen syndrome, which all nerves will be involved? There will be 9, 10 and 11th cranial nerve involvement will be there. Okay, so this is the pathophysiology along with the spread of skull base osteomyelitis. The bacteriology, it is a gram-negative Pseudomonas aeruginosa. This is the commonest organism, the most common, and this Pseudomonas aeruginosa is responsible for over 95% of cases of MOE. And it can also be caused by Staph aureus, mainly methicillin resistant Staph aureus. And Staph epidermidis also causes MOE. Epidermidis is also reported, and the fungus which is Aspergillus. Aspergillus is also reported as a causative organism. So, but Pseudomonas aeruginosa is the most common organism. Also, Staph aureus, Staph epidermidis, and Aspergillus causing malignant otitis externa is reported. Okay, there are some predisposing factors also for this malignant otitis externa, and the most important one is diabetes. both type 1 and type 2 diabetes patient are prone for malignant otitis externa. And why it is more common in diabetic patient? Because of mainly for three reasons. One is in a diabetic patient, especially in a long-standing uncontrolled diabetes patient, there is small vessel vasculopathy and there is also immune dysfunction. And also the cerumen of the patients, of diabetic patient, it is of high pH, so that will reduce the bactericidal properties of the cerumen. And there is also impairment of phagocytosis of the external auditory canal, especially in type 1 diabetic patient. So because of these reasons, the diabetic patient are more prone for a malignant otitis externa. There are also some other immunodeficient conditions which can lead to MOE. And HIV/AIDS, patients on malignancy and patients having chemotherapy. These are all predisposing to MOE. And in an adult patient, especially non-diabetic patient, if there is refractory malignant otitis externa, you have to do the biopsy of the granulation tissue because we have to rule out an histiocytosis and also malignancy of the temporal bone. Okay, so these two are the differential diagnosis which can mimic a MOE, histiocytosis and malignancy of temporal bone. So that is the importance of doing biopsy of the granulation tissue, especially in non-diabetic patients mimicking a MOE. Clinico-pathological staging. How will you stage? There are 4 stages. So the stage 1 is, there is clinical evidence of malignant otitis externa and involvement of the infection of the soft tissues beyond external auditory canal. Okay, and soft tissue involvement beyond external auditory canal, but technetium 99 bone scan is negative. Okay, so that is stage 1. And in stage 2, similar to stage 1, it is beyond external auditory canal. There is clinical evidence of MOE with the soft tissue infection beyond external auditory canal, and technetium 99 bone scan will be positive. If it is negative, it is 1, and if it is positive, it is 2. And 3 is again divided into 3A and 3B. That is depending upon the cranial nerve involvement. Okay, so if there is cranial nerve involvement, single cranial nerve involvement, it is 3A. And it is multiple involvement, it is 3B. That is stage 2 beyond external auditory canal, and the technetium 99 bone scan is positive, and if there is single cranial nerve involvement, it is 3A, multiple cranial nerve involvement, it is 3B. And in the stage 4, all these, that is there is soft tissue involvement of the beyond the external auditory canal, technetium 99 bone scan is positive, there is cranial nerve involvement, and also if there is meningitis, if there is empyema, then sinus thrombosis, or there is brain abscess. Okay. So this is how the MOE is divided into 4 stages, and this diagnosis is mainly by the history and also by physical examination and investigation, both laboratory as well as radiological investigation. So in the history, mainly the patient will be diabetic. In 90% of cases it will be diabetic, especially uncontrolled long-standing diabetes, or in some cases there will be other features of immunocompromised state that I already explained it along with the predisposing conditions. And there will be otalgia, means earache. Earache, especially deep-seated severe pain, more during night hours. So severe deep-seated nocturnal otalgia. and also otorrhea, mainly purulent discharge from the ear. There will be temporal headache, and if there is other cranial nerve involvement, there will be dysphagia, hoarseness or facial nerve dysfunction. And on examination, one thing, the pain will be out of proportion to the physical finding. Then there will be mastoid tenderness, especially at the tip of mastoid and also between the tip of mastoid and the mandibular ramus. And purulent otorrhea will be there, and you can see granulation tissue in the external auditory canal, especially at the floor of the bony cartilaginous junction. The floor of external auditory canal at the junction of bony and cartilaginous part. Okay, granulation tissue. And you have to examine the cranial nerve from 5 to 12. All these cranial nerves should be examined. So, history and also physical examination. Now, what are the investigations to be done in a case of MOE? The next in the diagnosis is laboratory study. Usually, the WBC count will be normal or slightly elevated, and because of inflammation, the inflammatory markers, they are the ESR and the CRP will be elevated. And usually, the ESR is more than 100 millimeters per hour, and the mean rise for ESR is 65 millimeters per hour, and for CRP it is 25 milligram per deciliter. Okay, and this CRP and ESR should be regularly monitored, and they start to decline usually 2 weeks after initiation of therapy. So these two are very important, and the cultural sensitivity of the discharge as well as the granulation tissue from the floor of external auditory canal has to be sent so that the appropriate antibiotic can be started. So under laboratory study, mainly ESR and CRP are the important markers. And coming to the radiology, mainly CT, MRI and also technetium and gallium scan. So the CT scan is basically HRCT temporal bone, high resolution CT scan of the temporal bone, and you can see obliteration of the fat plane in the subtemporal area and also destruction of the bony cortex of mastoid as well as the external auditory canal. And the second is MRI scan, and MRI scan is for precise location of the disease, that is the anatomical location, and also the extent of spread into the soft tissues and also into the cranial nerve. If there is cranial nerve involvement, the extent of spread into that area, and also if there is intracranial complication with MRI, you can precisely locate that. And if there is sinus thrombosis, if there is any other intracranial complication, MRI is very useful. But with CT and MRI, the limitation is that it is not useful for follow-up and also finding out the prognosis, because with both MRI and CT scan cannot differentiate between an active inflammation and also a resolving infection. So that is the limitation of this MRI and CT scan. There comes the importance of gallium and technetium scan. Technetium, that is technetium 99 bone scan, and this technetium bone scan will show body involvement or bone destruction even before high resolution CT scan shows evidence of bone destruction. Okay, so this technetium 99 scan is useful for detecting early bone involvement. Okay, so technetium 99 scan is mainly to find out the early involvement of bone or presence of osteomyelitis. Okay, and another one is gallium 67 scan. And this gallium 67 scan is more useful for tracking the disease process than the technetium. So technetium is for the early diagnosis, and the gallium 67 scan is more for monitoring than technetium. Okay, so technetium is for diagnosis and this gallium is for monitoring or the follow-up. Okay, so it gives more precise tracking of the inflammatory process than that of the technetium. Okay, so this is usually asked as MCQ. This technetium is for diagnosis and gallium is for monitoring MOE. And another marker is indium 3, indium 3 scan, and this is actually an alternative to gallium, and this indium along with technetium gives a very better um, diagnosis as well as a monitoring monitoring test for MOE. Okay, so combined technetium and indium is very good radiological investigation. And another one is positron emission tomography PET combined with CT. So that again there is localization and also monitoring of the disease process can be done using a PET and CT. So under the diagnosis, the first one is history, especially the deep-seated excruciating nocturnal pain. And on examination, the prominent finding is a granulation tissue, especially in the floor of external auditory canal at the junction of bony and cartilaginous part. In the laboratory study, mainly CRP and ESR, and the ESR will be usually more than 10 millimeters, more than 100 millimeters per hour, and the mean rise of CRP will be around 25 milligram per deciliters. And they are also good laboratory test, CRP as well as ESR, for monitoring the disease response to treatment. Okay. And in the radiology, CT and MRI, and technetium is for diagnostic purpose and gallium is for follow-up purpose, and a combined technetium and indium is more useful, and PET combined with CT is also helpful. And for the diagnosis, there are mainly two criteria. One is Levinson's criteria, another one is Friedman's criteria, and this Levinson's criteria is usually asked in exams. Okay, what is Levinson's criteria? You have to study this Levinson's criteria. There are 6 points in Levinson's criteria for the diagnosis of MOE. One is refractory otitis externa, that is otitis externa which is refractory to normal local therapy. Second one is a purulent otorrhea, there is purulent discharge from the ear. And third, very severe nocturnal earache, nocturnal otalgia. Then on examination you can see granulation tissue in the external auditory canal, exuberant granulation tissue in the external auditory canal, and cultural sensitivity, culture of the swab from external auditory canal will give Pseudomonas as report. Okay, so you can see Pseudomonas from the culture of swab from the external auditory canal, and presence of diabetes or other immunocompromised state. So these are the 6 criteria for diagnosis of malignant otitis externa as per Levinson. And there is another one which is Cohen and Friedman criteria. Okay, so Cohen and Friedman criteria for the diagnosis of MOE. So at least you remember this Levinson's criteria which is more popular, and the 6 points of Levinson's criteria for the diagnosis of MOE. The next is management. So mainly the oral toilet for symptomatic control, mainly for the removal of granulation tissue and also the cleaning of the discharge from the ear. That is very important. Oral toileting, frequent or daily basis clean the ear. And second is systemic antibiotics, mainly fluoroquinolone for a minimum period of 6 weeks, and this can be extended for several months. So ciprofloxacin with or without aminoglycosides and or ceftazidime. Okay, so mainly we use ciprofloxacin and ceftazidime. And implantable gentamicin beads are under trial nowadays, and if there is any contraindication for oral or systemic gentamicin, the implantable gentamicin beads can be used. So minimum period of 6 weeks. And hyperbaric oxygen can also be used along with the systemic antibiotics, and surgery is reserved for deteriorating patient, mainly for the removal of the sequestra or removal of the granulation tissue and also removal of the pus. That is the role of surgery. Okay, and we have to decide whether to perform surgery or not depending upon the condition of the patient, and also we have to set goals for performing surgery. So mainly oral toilet and systemic antibiotics, that is ciprofloxacin with or without aminoglycosides and or ceftazidime is the antibiotic usually used, and minimum 6 weeks, and this can be prolonged for months. Ideally, the response to treatment has to be monitored by gallium scan, and then also by laboratory test of ESR and also CRP, and then the treatment has to be planned accordingly. Okay. Now, what are the outcome and what are the complications we have to expect? The most common is a cranial nerve palsy. You know that the 7th facial nerve is commonly involved, and also along with facial nerve. So commonest involvement is of facial nerve, isolated involvement. Along with that there can be 9, 10 and 11th cranial nerve. And there is also involvement of 6 and 12th cranial nerve. Involvement is rare. So 7th is the commonest, 9, 10 and 11 can happen, and 6 and 12 is very rarely involved. And it will lead to skull base osteomyelitis, can go to clivus and to the opposite temporal bone. From there it can go anteriorly to the sphenoid and also to the carotid area. And anteriorly this can go to TM joint and also parapharyngeal space, leading to parapharyngeal abscess, then to retropharyngeal abscess. It can also go to internal carotid artery, thrombophlebitis, and also thrombosis of the internal carotid artery is seen as a terminal event. And if it is going to the central venous sinuses and then to the extradural space, or can go to the meninges, leading to severe intracranial complications. So these are some of the main complications, and if successfully treated, 22% of cases there is complete resolution of the facial palsy, and a partial resolution of facial palsy in another 9% of cases. Okay, so 22% if treated successfully, there is complete recovery of facial. This is all regarding malignant otitis externa.